know what will decide whether you will be successful or not? Not the vigor with which you started, but the vigor at which you continue every single day. The persistence, the perseverance, the consistency till the last day, till you achieve your goal. That is the only deciding factor whether you will reach your goal or not. If every single day you can continue with that sort of energy, with that sort of zeal, that sort of enthusiasm that I will drink the ocean, the mountains will crumple at my will. If this you can do every single day till the last day, there is no one who can stop you from reaching your goal. So don't give up, don't lose hope. Maybe sometimes you get tired, take a little break, but come back stronger, come back with more vigor, with more enthusiasm. With that, we start with yet another very important module, and that is the approach to vertigo and vestibular function test. So now in the previous module, I hope you've already seen it. If you have not seen it, please see it before you start this module. So in the previous module, we have seen completely which semicircular canal senses which motion, abnormality of which semicircular canal will present in what way, what is happening inside the semicircular canal, and ultimately the output is going to the eyes and to these vestibular, through the vestibular spinal pathway to our trunk and limb muscles to maintain our gaze and maintain our body posture. So if there is any abnormality of the vestibular system, that will lead to imbalance, and that imbalance will present as vertigo. Have you ever had vertigo? I mean, like sometimes when you were standing in the sun in the assembly and you felt dizzy and you fell down, or maybe you had a fast and you felt dizzy. Or maybe while sitting, you suddenly got up and you had a blackout and you felt dizzy and you fell down. Is that vertigo? So whenever a patient comes with the complaint of imbalance, the first thing that you need to rule out, you need to confirm is whether that the patient is stating is actually vertigo. It is not a hypotension, it is not a hypoglycemia, it is not any other condition. Yes, what is vertigo then? Vertigo is the sensation of spinning of either the surrounding or oneself. So if you are sure that this is a patient of vertigo, then this is how you will approach this patient. So what is vertigo? It is a sense of spinning. Spinning of oneself or surrounding. So whenever a patient comes to you with a complaint of vertigo, the first thing that we need to rule out is the most common cause of vertigo. And what is that? Yes, that is positional vertigo or BPPV. What is the full form of BPPV? It is benign, paroxysmal, positional, vertigo. Yes, paroxysmal because it happens in paroxysms. It is very episodic, lasts for a few seconds. Positional because it happens only on change of head positions. So do we know why this BPPV occurs? Yes, tell me quickly, where is the otolith present? Otolith? Yes, otolith is present in the utricle and saccule, in the maculae of the utricle and saccule. So if the otolith from the utricle, if the otolith from here, because of any reason that can be idiopathic most commonly, it can be because of head trauma, whatever the reason, it has got dislodged and it goes into any semicircular canal. Now just see here, can you make out that the ampullae of the posterior semicircular canal, the opening of the posterior semicircular canal is lowermost. Whether we are in standing or whether we are in the lying position, that is lowermost. So the otolith to go into the posterior semicircular canal is very easy. So that is why the BPPV is most commonly because of posterior semicircular canal. Yes, so most common is posterior semicircular canal. Next common is, second is, again, when I say second, it is second, but it is, yes, it is far way behind the posterior semicircular canal. Next is the horizontal semicircular canal. horizontal semicircular canal. The superior semicircular canal is rarely, very rarely, usually never involved. Why? Because it is superior. So for the otolith to go inside, first of all, not easy, and second, even if it goes, because it is in a superior position, it usually comes down also by itself. So usually what is present is most commonly posterior semicircular canal, followed by next is horizontal semicircular canal, and we will be focusing on this because this is what is asked in your exam. So now what happens is, when the otolith goes into these semicircular canals, whenever these semicircular canals get active, in which position they get active, we already know. They are placed in different planes. So when the patient places his head in that particular plane, and in that particular semicircular canal, if there is otolith which has got stimulated, that irritates the semicircular canal and that leads to vertigo. So now what happens is, that patient will give you the typical history that I am lying down, I am perfect. The moment I turn, the moment I change my posture, I get very severe vertigo. I am very scared. I keep my head still. You ask, okay, so then how long does it last? Just for maybe a few seconds, and then I'm okay again till I change my posture again. Yes. So what happens is that the otolith are calcium carbonate crystals. Because of gravity, they settle down. So the vertigo disappears in some time, in a few seconds, until the patient again changes his posture to make that particular semicircular canal active again. So whenever the patient has come to you with this typical history, whenever in your exam the question is given, there is the typical history that is given. So what is the history that is given? The history is, as the name, BPPV. So there is episodic vertigo, that is for a few seconds, on posture change. So now the patient has come to you with this complaint, and typically you know that this is the most common cause of vertigo, and you are sitting ready, okay, vertigo, BPPV, I know everything, how to test which semicircular canal, and if there is otolith or not, how it will present. We know that already. Yes, so how are we going to test which semicircular canal has got involved in this otolith, because of this otolith in this BPPV, is the next important step for us. Why? Because only when we know which semicircular canal is involved, what will be the management? Management will be to bring back the otolith into the utricle by a positioning maneuver. We position the head of the patient in a series of different positions to bring back the otolith into the utricle, and this positioning maneuver will be different for different canals. So the first thing is that we need to find out which semicircular canal this is. So what we do is we start testing the patient. So in this patient, what have I done? I have placed the head to the right. So which ear am I going to test? Yes, the right ear. And yes, now tell me, which semicircular canal are we testing here in this? Yes, this is the head is to the posterior. So we are testing, the head is towards the right. So this is right semicircular canal. Which semicircular canal? The head is right and posterior. So it is right posterior semicircular canal. And as I told you that the most common cause location for PPPV is the posterior semicircular canal. So this is how you always test. This is the first test that you do whenever there is any patient of suspected BPPV. And this positional maneuver to test whether it is BPPV or not of the posterior canal is what is known as Dix-Hallpike maneuver, a repeated question of your exam. The next most common canal where the otolith can go into is the horizontal semicircular canal. How will we test that? Very simple. We will just make the patient lie down and we have to stimulate the horizontal semicircular canal. So we will test the horizontal semicircular canal by just placing the head horizontally. This is the position. Towards the right, I am testing the right horizontal semicircular canal, and towards the left, I am testing left horizontal semicircular canal. So we test both these semicircular canals individually, both the ears, posterior and horizontal semicircular canal individually. And if there is otolith in the posterior semicircular canal, the moment you have placed the patient in this position, the posterior semicircular canal of the right side, if it has otolith, will get irritated and patient will have very severe vertigo. Not only vertigo, this abnormality of the inner ear of the posterior semicircular canal will also manifest as an abnormality in the vestibular ocular pathway as nystagmus. We have already seen that earlier in the previous module, that if the posterior semicircular canal is involved, how will be the nystagmus? Will it be a vertical nystagmus or will it be a horizontal nystagmus or vertical? Yes, there is a vertical canal. Nystagmus is always in the plane of the canal. So it will be a vertical nystagmus. It will be a vertical nystagmus, and also we saw that it is always with a torsion. There is a component of torsion present whenever there is an abnormality of the ear, peripheral pathology. Similarly, in this patient, if there is otolith in the horizontal semicircular canal, this posture will immediately make the patient very vertiginous. Along with that, you will be able to see nystagmus. When the patient has vertigo, you will be able to see nystagmus. So whenever you do this, the moment you start seeing nystagmus, you can tell the patient that your vertigo has started. Right? And the patient will be surprised that how come you have come to know that the vertigo has started. And the moment the nystagmus disappears, you can tell the patient that, okay, so now you're fine, and the patient will think that you're a magician, right? Okay, so there also will be nystagmus. And what nystagmus are you expecting if this is a horizontal canal BPPV? Yes, in this patient, you will get a horizontal nystagmus. Horizontal with torsion. So there are certain characteristics that the nystagmus of origin of the inner ear or of the peripheral pathology, that is the inner ear or the nerve, have. And all these characteristics of nystagmus are asked in your exams, which means that the moment you make the patient lie down in this position, what is the type of nystagmus that you will get? You already know it is vertical and it is with torsion. Let us see some other things that you're going to notice in this nystagmus. So this nystagmus always will have a latency. So what is the meaning of latency? Latency means that the nystagmus will start after some time. The moment you make the patient lie down in this position, you do the Dix-Hallpike or the supine roll test. The test for testing the horizontal semicircular canal, BPPV, this is what is known as the supine roll. This is supine roll test. So you will see that the nystagmus immediately does not appear. It appears after maybe a few seconds, maybe 10 seconds, maybe 20 seconds. Yes. And also, as I told you that after some time, what happens? The nystagmus disappears. So it is limited for a particular duration. Maximum for 1 to 1.5 minutes, it will be there. Not this much also. It can be a few seconds also. And it will be fatigable. What's the meaning of fatigable? Fatigable means, okay, after some time it will become less and then it will disappear. Is that what is fatigable? No. What is fatigable? That is a duration. No, it appears and it disappears after some time. That is a duration. What is fatigability? Fatigability means repeatability is not there. You make the patient lie down in this position once, you get the nystagmus. You and vertigo. Again do it. Maybe you will get it. Next time again do it, you will not get it. So it is fatigable. This nystagmus, peripheral origin nystagmus, is always fatigable. So it is always fatigable. Fatigability is present. And we know if it is a vertical canal, so it will be in the anterior and in the posterior semicircular canal. It is going to be a vertical nystagmus. In horizontal semicircular canal, it is going to be a horizontal nystagmus. And yes, it will be with the torsion. It will always be with the torsion. And very, very important question of your exam, very, very important characteristic of peripheral nystagmus is that it disappears by optic fixation. What's the meaning of optic fixation? You ask the patient to fix the eye on something and you see that the nystagmus disappears. So that is why whenever you're testing for peripheral nystagmus also, yes, I know how you test nystagmus is you ask the patient to look at your pen and then you tell that, okay, follow my pen and look at the pen here, look at the pen. This is not how you will test the peripheral nystagmus. Yes, if you just want to test the peripheral nystagmus, a spontaneous nystagmus, you just have to let the patient be. Just let him gaze anywhere. Yes, you don't have to ask him to fix the eye. The moment he fixes the eye, nystagmus will disappear. And many a times, because you do not want the patient to fix the eye, what we do is we give the patient a type of glasses. Yes, this is what is known as Frenzel glasses. This is Frenzel. What is this glasses? This is a very high diopter glasses, plus 20 diopter glasses. So it is such high diopter that the patient will not be able to fix on. Even if he wants to fix the eye, he will not be able to fix the eye. And second, as you can see here, that these glasses, they magnify the eye. So you will be able to see nystagmus very, very clearly when it has appeared, when it has disappeared. The characteristics of the nystagmus you'll be able to see very clearly. So yes, optic fixation. On optic fixation, it will disappear. It will disappear. Now, another very important characteristic of nystagmus, of peripheral nystagmus, that we need to know is that the direction of a peripheral nystagmus is always fixed. If it is towards the right once, no matter how many times you test, if there is nystagmus, it will be towards the right. If it is towards the left once, no matter how many times you test, it will always be towards the left. Is that clear? So you must be thinking, direction of nystagmus, what does that mean? What is nystagmus? Nystagmus is involuntary oscillatory movement of the eye. Oscillatory movement of the eyes means that the eyes are moving in both the direction. So what then is the direction of nystagmus? Yes, always remember, the peripheral origin nystagmus is not a equal oscillatory movement. It is always a nystagmus, a movement of the eye like a jerk. Like a jerk, yes. What is the jerk? The jerk has a slow component where the eyes move slowly towards one direction and then fast towards the opposite direction. So slow and fast. So always remember that whenever there is a jerk nystagmus, there is a slow component and there is a fast component. Before we see how nystagmus looks like, now yes, I know that most of you will be seeing nystagmus for the first time in this video. In fact, you will be seeing nystagmus for the first time in your life. So yes, when you see the nystagmus repeatedly again and again and again, only then you are actually able to make out the fast component. You are able to make out the direction of nystagmus. You are able to make out the torsion is there or not. So these videos, what I am focusing on is everything, but just try to notice the gross things. Whether you are able to notice what nystagmus it is, when you see repeatedly, you will be able to notice what the direction is and whether there is torsional component or not. So that next time when you go to your clinics, when you actually examine the patient, at least there is a nystagmus in the patient you should be able to identify. If that much you are able to identify, then the purpose is solved. Before you see the video for how a nystagmus of the peripheral and how a nystagmus of the central origin, how the nystagmus of BPPV or how nystagmus of vestibular neuritis, how they appear. Yes, my dear students, I know that most of you would be seeing the nystagmus for the first time. So yes, just try to notice the gross things in the nystagmus, whether you are able to make out or not that there is a nystagmus. If possible, yes, what the direction of nystagmus is, so that when you go to the clinic, if you see any patient, at least if you are able to make out that there is a nystagmus, would be a wonderful thing. When you see it repeatedly again and again and again, it is only then that you actually can see and tell immediately, yes, that this is the direction of nystagmus. Yes, this is a nystagmus which is vertical, which is horizontal, or there is a torsion associated with that. So when you see this video also repeatedly, you will see that you are able to appreciate the things better. Yes, if you are expecting that you will see it once and you will know everything, that will be maybe expecting a little too much from yourself. So just see this video and try to appreciate the gross things. Later on, when you see it repeatedly again and again, yes, you will be exactly, the moment you see the nystagmus, you will be able to say that this is this direction nystagmus, this is a horizontal or vertical nystagmus, it is associated with torsion or not. So yes, let us now have a look. This is a patient who has come with a history of vertigo whenever she turns towards the left. And yes, it is a very episodic vertigo lasting for a very few seconds. And this typical history is very much suggestive of a positional vertigo, that is BPPV. So we are going to test her first for BPPV, and for testing for BPPV, yes, the most common canal involved is the posterior semicircular canal. The typical history that she is giving is or towards the left side, so that is being tested here first. Definitely, if the patient does not give such a history, we have to test of both the sides. Even if she is giving such a history, it is always better to test both the sides. In this patient, what is being shown to you is the left canal being tested. Yes, can you make out? Can you see and tell that the head of the patient is turned towards her which side? Towards her left. So we are testing her which ear? Yes, we are activating her left canal, her left ear, and we will place her in the position of activation of the left posterior semicircular canal. If in her left posterior semicircular canal there is otolith, when that semicircular canal gets activated in that particular position, otolith will move, irritate the semicircular canal, and that will lead to very severe vertigo in the patient. Along with that, what we will be able to see is the nystagmus. So in this patient, the nystagmus will have all the characteristics of the peripheral nystagmus. Yes, what are they? Before we start, I will like to tell you so that you can focus on these things. The nystagmus will have a latency, which means the moment you make the patient lie down, the nystagmus will start after a few seconds. The nystagmus will disappear after some time. Since it is because of posterior semicircular canal, so posterior semicircular canal is a vertical canal, so the nystagmus will be vertical and it will have a torsional component. The direction of nystagmus will be towards which is the hyperactive ear, that is here we are testing the left posterior semicircular canal, so it will be towards that ear. Yes, so let us now start and let us see how the nystagmus will appear. So now we are starting the Dix-Hallpike test. We are testing a left posterior semicircular canal. No nystagmus. Yes, now the nystagmus has started. So it had a very short latency of a few seconds. We are seeing it is a vertical nystagmus with a torsion, and you can see that the torsion is towards the fast component was towards the left ear. Now the nystagmus has disappeared. The nystagmus will be in both the eyes, it will be same. Here the right eye is being shown to you so that you can see it clearly in one eye. It does not mean it is in only this eye. See the vertical component which has a torsion, and yes, it is towards the downmost ear, towards the ear which is in the dependent, which is activated, that is towards the left ear. And the torsion is also towards the fast component. The fast component is the direction of the nystagmus. And now we can see that the nystagmus has disappeared. So yes, all these are the characteristics of the peripheral nystagmus. Another patient, again the left posterior semicircular canal is being tested. We can see no nystagmus as of now. Yes, it has started, so it had a latency. And yes, again, it is a vertical nystagmus because of involvement of the posterior semicircular canal. See, in both the eyes, the same movement, the conjugate movement. Nystagmus is seen, both the eyes same. It is a vertical nystagmus. Now it has disappeared. Now you will be able to see a closer look in, yes. So here we are seeing a vertical nystagmus. The fast component is the direction of nystagmus. Here again, it is towards the left ear. That is the ear that we are testing. That is the posterior semicircular canal that has got stimulated. So the nystagmus is towards the ear which faces the ground. That is the one that we always stimulate. To stimulate it, we have to place it towards the ground. So now we are seeing that it has slowed down, and yes, it will disappear. So if the patient who has come to you with a complaint of episodic vertigo lasting for a few seconds on posture change, and all this history which is suggestive of BPPV, the next step is to do a Dix-Hallpike maneuver to rule out a posterior canal BPPV. If it is negative, then we go for a supine roll test, that is to rule out a horizontal canal BPPV, which is the next most canal to be involved. So in this patient where the Dix-Hallpike test was negative, a supine roll test is being done to rule out a horizontal canal BPPV. So to test the horizontal canal, we know that we will have to place the head of the patient in the plane of the horizontal canal. That is, we will have to turn the head horizontally to the right to test the right ear and to the left to test the left ear. And if there is otolith in the horizontal semicircular canal, what will be the type of nystagmus? Yes, it will be horizontal nystagmus with torsion, and the direction will be the fast component, and the fast component or the direction will be towards the hyperactive, that is towards the more active ear, the ear that is involved. Yes, so now in this patient, we are turning the head horizontally to the right. So if there is otolith in the right horizontal semicircular canal, we will see a horizontal nystagmus. Yes, so let us see this patient. Yes, so we have turned the head to the right, initially known as nystagmus. Now we can see a horizontal nystagmus with torsion. So yes, again here we are testing the horizontal semicircular canal, horizontal plane, no nystagmus initially, so there is a latency. Now you can see a horizontal nystagmus, signifying that there is involvement of horizontal semicircular canal, and yes, it has disappeared. So it has all the characteristics of the involvement of the peripheral horizontal semicircular canal. And now, according to which semicircular canal it is, whether the Dix-Hallpike is positive or the supine roll test is positive, we can go for the management of the patient. So the jerk nystagmus, jerk or the peripheral nystagmus is always a jerk nystagmus, peripheral nystagmus. It has a slow component and it has a fast component. Yes, the slow component is because of disease. Slow component is because of disease. Whereas what is the fast component? Fast component is the corrective phase. Corrective phase. Yes, before proceeding, let us first understand this. Yes. Now suppose in this case, what is happening is that the labyrinth is becoming hyperactive. Okay, so the right labyrinth has become hyperactive because of otolith inside one of the semicircular canal. So now what will happen is, normally what is the function of the labyrinth? The right pushes the eye to the left pushes the eye to the right. Equal and opposite, so that the eye is kept in the midline. Now what will happen now when the right has become hyperactive? This will push the eye more towards the left. So the eye will slowly move towards the left. Yes. Now the brain will think, why is the eye moving towards the left? It is supposed to be in midline. It will immediately correct it. Yes. So again it will slowly move towards the left. Again brain will correct it. So the slow component, why is the slow component? Yes, because of the disease, because this has become hyperactive. So it is pushing the eye more towards the left. And the fast component is the corrective phase. Is that clear? So now you understand, slow is because of the disease. What is the fast? Fast is because of the corrective phase. And when I do like this, see the movement of the eye. Yes, it is like this. So this is slow, fast. But are you able to notice that slow component you are not able to see very clearly? What you are able to see is the fast component. That is why the direction of the nystagmus, because this can be very easily seen. It can be very easily noticed. The fast component. So the direction of nystagmus, we call it as the direction of the fast component. So the direction of nystagmus is the fast component. Is that clear? It is always the direction of fast component. Okay. Now again, let us take another scenario. Okay. What scenario? In this scenario, what I told you is that the right labyrinth has become hyperactive. Now, if one of the labyrinth becomes hypoactive, what will happen? Now, suppose if the left labyrinth becomes hypoactive, it is not functioning. Now, what will happen? The right one is normal. It will push the eye towards the left, but the left is not functioning. It will not be able to push the eye back. So, the eye will slowly move towards the left. Brain will think, why is it moving towards the left? It is supposed to be in the midline. It will correct it. Slowly move towards the left, again correct. Slowly towards the left, again correct. Here again, are you seeing that the slow component? Why is the slow component? Because of the disease. Because this is not able to push it back. And the fast component is the corrective phase. Is that clear? So that we have understood the slow component is always because of the disease. This is a question that is asked in your exam. Slow component is because of the disease. We always think that, okay, fast component is what? Fast component is the direction of nystagmus. So we are able to see the fast component very nicely. The fast component is telling us the direction of nystagmus. So that is towards always the disease. No. The slow component is the generator. The disease is the generator of the slow component. The center, the corrective, is the generator of the fast component. The fast component might be towards the disease or away from the disease. Listen to this again. Okay? This is another thing that I'm telling you, that the fast component, the direction of nystagmus, can tell you which is the side of involvement. I will first write it down for you, then we will see what it means. Okay, the direction of fast component, the direction of nystagmus is the direction of fast component, and it is always towards the more active side. More active here. What does it mean? Let us take the first scenario. One ear is hyperactive. Hyperactive as in there is otolith inside one of the semicircular canal which has made the ear hyperactive, and the other ear is normal. The other ear otolith has not gone, so it is normal. Okay. Now in this case, which is the more active ear? More active ear is this one. So nystagmus will be towards the hyperactive side. Yes, so direction will be towards the hyperactive side. Second scenario is that one ear has become hypoactive. Hypoactive means it has got destroyed, like in Meniere's or in vestibular neuritis. Vestibular neuritis. What's vestibular neuritis? It is a viral infection of the vestibular nerve leading to complete destruction of the nerve. So in that case, the labyrinth or the peripheral system has become hypoactive. Yes, and the other ear is normal. Now, which ear becomes the more active here? In this case, the normal becomes the more active. Yes, so here the nystagmus direction will be towards the normal. So the direction of nystagmus is always towards the more active ear. Now I will repeat this for you and you will understand it very clearly. This is the hyperactive labyrinth. In this ear, in the right ear, in one of the semicircular canal, otolith has gone. This is normal. Okay. Now this hyperactive ear will push the eye more towards the left, slow component. The brain will push it back. Yes, again slowly, corrective phase. Slowly, corrective phase. Which is the diseased ear here? Which is the more active ear here? More active is the hyperactive. So tell me, nystagmus is towards which direction? Towards the more active. Now suppose this has become hypoactive. The left ear has become hypoactive. Now what will happen is the eye will move towards the left. Left will not be able to push it back. So slow component, corrective phase. Slow component, corrective phase. Slow component, corrective phase. So what is the fast component here? Fast component is towards which side? This is the hypofunctional. It is towards the more active side. That is the normal side. So the direction of nystagmus tells you two things. First, if the direction is fixed, if it is always, no matter how many times you test, if you get nystagmus once towards the right, always towards the right, it is always signifying that it is a disease of the ear. It is a peripheral pathology. Whereas also the direction of nystagmus tells you which is the diseased ear. If there is nystagmus, now this question is for you. Sit straight. Tell me, if there is nystagmus towards the right, what can be your two DDs? It means that either the right ear is active, which means the other one is hypoactive, or this is hyperactive, the other is normal. Is that very clear? Yes? Is that very clear? Okay. So what we saw is that the direction is always fixed, and the direction of nystagmus, here we are dealing with BPPV, which is a hyperactive lesion. So direction of nystagmus will always be towards the more active, that is the involved side. And yes, what is the fun of taking so much of pain to know which ear is involved? Only when we know which semicircular canal, we will be able to revert. The reverting maneuver for this ear and this ear will change. Is that clear? So here, in this patient, we are testing right with semicircular canal, posterior semicircular canal. If there is otolith in the right posterior semicircular canal, how will be the nystagmus? Will there be a latency? Yes or no? Yes, latency. Will it be limited for a particular duration? Yes. Will it be fatigable? Repeatability, will it be there? Yes or no? Repeatability will not be there. It will be fatigable. Will this nystagmus disappear by optic fixation? Yes or no? Yes. How will be the plane of this nystagmus? Will it be vertical? Will it be horizontal? Yes, this is a vertical canal. So the nystagmus will be in the plane of the canal. It will be a vertical nystagmus with the torsional, with a component of torsion. And the direction of nystagmus, tell me in this patient, if there is otolith in the right posterior semicircular canal in this patient, what will be the direction of nystagmus? The direction of nystagmus is always towards the more active side. So hyperactive labyrinth, the more active side, this is the right posterior semicircular canal involved, which is more active. Right labyrinth is more active. So the direction of nystagmus here in this patient will be a vertical nystagmus and towards the right side. Towards the right side. The torsion that you will see will be towards the right side. The direction will be towards the more active side. Is that clear? Yes? Or if you are testing the horizontal semicircular canal, yes, when you are turning the patient's head horizontally, if there is, you can do it just by making the patient lie down straight and turn the head horizontally, or you can lift the head 30 degrees. This makes the horizontal semicircular canal more responsive, and then turn the head horizontally to whichever side you are testing. In this case, I am testing which ear? Yes, the right ear. And which semicircular canal? Horizontal semicircular canal. So here, what will be the characteristic of nystagmus? Now you are going to tell me all this. Latency, yes or no? Direction fixed, yes or no? It will be always towards which side? Which side? The more active side. In this case, if there is in the right horizontal semicircular canal, nystagmus will be more towards the, yes, the direction will be towards the right side. And what is the direction of nystagmus? Direction of nystagmus is the fast or the slow component. It is towards the fast component. The slow component is because of the virtue of disease. Yes or no? Slow component is because of disease. Fast component is the corrective phase. Yes or no? Yes. So which means overall what we now know is that whenever a patient has come to you with vertigo in the OPD, if he's typically giving you the history that I have vertigo, whenever I change my posture, what are you going to think? BPPV. Yes. What is your next aim? You are thinking that this is BPPV. Do you want to confirm it is BPPV or not? Yes. Do you also want to find out which semicircular canal is involved? Yes. What is the test for posterior semicircular canal known as? Dix-Hallpike maneuver. What is the test for horizontal semicircular canal known as? Yes, supine roll test. More common is posterior or horizontal semicircular canal? Posterior semicircular canal. Yes, so if it is positive, you know which position, if any position is given, in any picture is given like this, will you be able to tell which semicircular canal is being tested? Yes, if it is asked in this patient, if the test is positive, what will be the nystagmus characteristics? Will you be able to tell all the characteristics of nystagmus? Yes, will you be able to tell when it will be horizontal, when it will be vertical? Yes, direction of nystagmus is the corrective phase. Yes, it is the corrective phase, and direction of the nystagmus is direction of fast component or slow component? Fast component. So now let us quickly have a look at how actually the nystagmus of BPPV looks like. So now you saw that whenever there will be a BPPV of the left semicircular canal, posterior semicircular canal, how you are testing and how it will, if it is positive, how you will see the positive result. And if it is positive, then what you're going to do is a reverting maneuver, which is known as the Epley's maneuver. This we'll see in detail when we do the BPPV separately. In this module, what we are doing is how we test the patient who has come to us with vertigo. And yes, I'm so proud of all of you. All of you message me so many number of times. My uncle, my aunt, my friend, my relative, my parents, they had very severe vertigo. We could make out it is BPPV. Not only we could make out, we could also test it appropriately, which semicircular canal it was, and we could treat it appropriately, and it felt like magic, and everybody was really proud of us. Yes. So now you are sitting in the OPD and here is a patient who has come to you with a complaint of vertigo. So, okay, the moment you hear that, okay, I am having my head spinning, everything is going round. So immediately you ask, okay, what was aggravating, and you are waiting that he will tell you that the moment I change my head posture, I have vertigo lasting for a few seconds, and you are ready to do the hall pike or the supine roll test and then correct it by a place and look like a magician. But the patient tells you that I am having continuous vertigo for maybe a few hours, 2 or 3 hours, or maybe 2 or 3 days. Yes. So now this cannot be PPPV. What else can it be? Yes, then you need to rule out a hypofunction of the labyrinth. Hypofunction, a destruction of the labyrinth. If the labyrinth has got destroyed of one side, obviously it will not be able to balance, and that can lead to vertigo. So if there is a hypofunction of the labyrinth, as in conditions like Meniere's initially there is a hyperexcitable labyrinth, later on it gets destroyed, and that is a destructive lesion. Or more important and more important condition is a vestibular neuritis. What is vestibular neuritis? It is acute infection of the vestibular nerve. Yes, vestibular neuritis. Vestibular neuritis. It is acute infection of the vestibular nerve. So whenever there is a hypofunction of the labyrinth, acute hypofunction of the labyrinth of one side, again the patient will present with vertigo. And how can you find out whether it is because of labyrinth or not? Yes, we have seen that the vestibular system is responsible for maintaining our gaze by the vestibular ocular pathway. Yes, so if there is any abnormality of the inner ear here or any abnormality of the nerve here, this will manifest as abnormality of the vestibular ocular pathway presenting as nystagmus. Yes, so the characteristic of nystagmus will tell you whether the inner ear is involved or not. Why we need to know by the characteristic of nystagmus that the inner ear is involved or not? Why? Because just see here. We know that the vestibular system has interconnection with the center also, with the cerebellum also. Yes. So, if there is any abnormality of the central system, for example, a cerebellar stroke, again, it will lead to abnormality of the connection at the level of the vestibular nuclei. This can also manifest as an abnormality of the vestibular ocular pathway presenting as nystagmus in the eyes. That is why we need to know when the patient has vertigo along with nystagmus. If the nystagmus is present, by seeing the nystagmus, how we can find out whether the lesion is at the level of the periphery or it is at the level of the center. And believe me, this is such an important responsibility on the doctor who is examining the patient, on the doctor to whom the patient has come to for this condition. Why? Because just imagine the patient is having vertigo because of the cerebellar stroke. Yes, okay. This cerebellar interconnections where they are present along with the vestibular nuclei, there we have multiple cranial nerve nuclei also. So there can be other features like involvement of other nerves. This is the nuclei of 8th nerve. So around the 8th nerve, we have which nuclei? We have the 6th nuclei, we have the 9th, 10th, 11th nuclei, which means that along with, and stroke is not that it will involve only that vestibular nuclei area. Yes, so if the interconnections with the vestibular nuclei are involved, probably the interconnections with other nuclei there also will be involved in stroke. So the patient will have, because of involvement of 6th nerve, there will be diplopia. Because of involvement of the 10th, the 11th nerve, there will be dysphonia, there will be dysarthria, there will be dysphagia, there will be ataxia because of cerebellar involvement. So all these features will tell you whether it is an intracranial abnormality or not. But many a times, these features appear late And the earliest feature that the patient is having is only vertigo. And if this vertigo is because of a cerebellar stroke, the onus is on you to immediately identify it, because if this is the golden period where if you start the patient on medication, the stroke will not progress and it will revert. So whenever the patient has come to us with vertigo, which is not episodic, which is not suggestive of BPPV, which is continuous for a few hours, then we need to rule out whether it is a peripheral pathology or it is a central pathology. So the first is by history. Yes, so if the patient is having any inner ear pathology, peripheral pathology, then along with vertigo, it is likely that the patient might be having hearing loss. The patient might be having hearing loss, as in Meniere's. Yes, but the important condition that we are dealing here, it is the vestibular neuritis. It is specifically only the infection of the vestibular nerve, where any other inner ear features are not present. No hearing loss, no tinnitus, nothing is present. So anyway, you will ask for a history of peripheral features like hearing loss, tinnitus, and if that is present, that gives you the hint that this is a peripheral pathology. Now, if it is a central pathology, again, you will ask the history, you will talk to the patient, you will know that there is dysphonia or not, 10th nerve. You will examine the eye movements, you will see whether there is diplopia or not. Yes, so you will look for diplopia. The moment the patient has entered the OPD, you will be able to see how his gait was, whether it was ataxic or not. So, ataxia, dysarthria. Yes, you will ask history of sudden onset, muscular weakness, motor weakness. Of sudden onset, very severe headache. So yes, all this history is very, very important to differentiate whether it is a peripheral or central. Now, what is our diagnostic dilemma is when none of these features are present in the patient and the only complaint that the patient has is vertigo. So now, what we look for, our life savior, is the nystagmus. The characteristic of nystagmus is what we look for now, and that will tell us whether it is a peripheral origin or a central origin nystagmus. So here, the peripheral origin nystagmus, the nystagmus of vestibular neuritis, is always a horizontal nystagmus with torsion. Yes, whereas a central nystagmus is either a pure horizontal or a pure vertical. Now you must be wondering that horizontal nystagmus we get when the horizontal semicircular canal is involved, as it is in horizontal BPPV. So when there is complete hypofunction of the labyrinth of one side, why we have horizontal nystagmus? I will just show it to you. I will just tell it to you in some time. Yes, for now we are just seeing what the other features will be. Tell me optic fixation. In peripheral nystagmus, will the nystagmus disappear by optic fixation? Yes or no? Yes, optic fixation, it will disappear. Whereas central nystagmus will not disappear. It will not disappear. Tell me about the direction of nystagmus. Direction of nystagmus, if it is a vestibular neuritis, it will be always fixed. If it is towards the right, it will be towards the right. If it is towards the left, it will be towards the left. And whereas a central nystagmus is a direction changing nystagmus. Direction changing nystagmus. Here is a patient who is in the ward and you are testing for nystagmus in the patient. You see that the patient has nystagmus towards the right. When your consultant comes for round, you are telling that nystagmus is towards the right, and the consultant, when he is testing, nystagmus is towards the left. Who is correct? It means it is a direction changing nystagmus, and direction changing nystagmus is always of central origin. Always of central origin. Is that clear? Direction changing. Whereas in peripheral it is always fixed, and not only it is fixed, before that, yes, direction is what? Fast component or slow component? Yes, direction is the fast component. And if in hypofunction of the labyrinth, can you tell me the direction will be towards which side? Yes, how do we remember? The direction of nystagmus is always towards the more active side. So if one ear is hypoactive and the other is normal, so which is the more active? normal side. So direction will be towards the normal. Towards the normal. So if the direction of the nystagmus in a patient who has come to you with acute severe vertigo for few hours, you are asking for history. There is no history of peripheral involvement or central involvement. So now your life savior is nystagmus. You look for the nystagmus, spontaneous nystagmus, or when the patient moves his eye, you are looking for nystagmus. And what you see is, yes, there is nystagmus. The nystagmus you are seeing is a horizontal nystagmus with the direction fixed. So you have confirmed that this is a peripheral origin nystagmus. You fix the eye and you see that the nystagmus disappears. You more confirm that yes, there is a peripheral origin nystagmus. Now, if the nystagmus is towards the right in this patient, where you have confirmed that this is the peripheral origin nystagmus because of destruction of the labyrinth. Nystagmus is towards the right. Tell me, where is the disease? Nystagmus is always towards the active ear. So here the disease is towards the left ear. If the nystagmus is towards the right, disease will be towards the left ear. Is that very clear? Now, I told you that I will tell you why a complete hypofunction of the labyrinth leads to a horizontal and torsional nystagmus. You want to know, or should we leave it? What? Yes. If you don't want to see that, you can skip that part. But why I will tell this is, so many of you ask me that why it is horizontal. Horizontal is because of horizontal semicircular canal. So if the complete labyrinth has got destroyed, why it is horizontal? So if you still want to know, I will just tell you it. You need not remember exactly how, but yes, what you remember is that if there is a complete destruction of one labyrinth, nystagmus will be a horizontal nystagmus with torsion. Why it occurs, that I will tell you now. Okay. Now suppose in this patient the left labyrinth has become hypofunctional, it has got destroyed. Okay, so now what will happen is only the right labyrinth is functional. So the right labyrinth, the semicircular canals will set impulses. Now each of the ears, they supply conjugate muscles of both the eyes. When the eyes move, only one eye does not move, no? If I am looking towards this side, only this eye is not moving. This eye will also move. It will be always a conjugate movement of the eyes. If I am looking up, only this will not move up. Both will move up. If I am looking down, both will move down. Yes. So the semicircular canal of one side, they supply not only one muscle, only of this eye. They supply conjugate muscles of both the eyes. Okay. So here the superior semicircular canal, now only one is functional. Okay. Which is functional? Only the right is functional. So in the right ear, now the right semicircular canal, what it supplies is that usually it supplies also the superior rectus of the right eye. Okay, and that will make the eyes move above superiorly. Adduction means the eyes will go up. It will go adduction and intorsion. Is that clear? And conjugate of the other also. The other will also move up like this and up, and there will be intorsion, which means that superior semicircular canal is making this action to happen. Whereas the posterior semicircular canal, what is the action that it is leading to? It is stimulating the superior oblique of this side. So that will lead to a downward movement. So that will lead to a movement downwards, that is inferiorly, and abduction. Same in the other eye also, downward, and a movement like this, a conjugate movement. And again it is intorsion. Which means that now what will happen is, what will be the resultant movement? Okay, don't get confused, just a few seconds, yes. So what will be the resultant movement? The superior movement and the inferior will cancel each other. The adduction and the abduction will cancel each other. So ultimately what is left is only intorsion. So the resultant movement of the superior and the posterior, the action of the superior and the posterior of the normal side, which is the right ear here, will be only a intorsion. Is that clear? When I am talking about the intorsion, I am talking about that eye. The opposite eye obviously will go for a conjugate movement. And the horizontal, left is horizontal, we are left with the horizontal semicircular canal. Horizontal semicircular canal, what it does, it supplies a medial rectus. It leads to a horizontal movement of the eye, conjugate movement. So what is the ultimate movement that we are left with? If there is hypofunctional of one ear, the other ear, the active ear, leads to the movement which is a horizontal movement of the eye with intorsion. Okay, so here what is happening in this case is that the left has stopped functioning. Okay, so this is the right ear, the left has stopped functioning. So the right superior function, superior semicircular canal and the posterior semicircular canal actions cancel each other. Left is only intorsion, and the lateral semicircular canal function of the normal ear, that is a horizontal movement. So ultimately, how is the eye moving? Horizontally and with intorsion. Yes. So this normal eye will push the eye towards the left. Here the left is not functioning. It will not be able to push the eye back. So I will slowly move towards the left. Again, there will be a corrective phase. Slow component, fast component. Slow component, fast component. So fast will be towards the active side, that is the normal side. So if you have understood this, I hope you've understood this. That is wonderful. If you want to skip this part, you can just skip it. But you have to remember that if there is a complete hypofunction, nystagmus will be a horizontal with torsion, and it will be towards the active side, towards the normal side. So now let us quickly have a look at how the nystagmus of vestibular neuritis will look like. So to summarize, we now know that whenever a patient comes to us with vertigo, the first thing we think of is BPPV, how we rule out a BPPV, how we diagnose which canal it is, accordingly will be the management. If the patient has come to us with continuous acute onset vertigo, how we differentiate a vestibular neuritis from a cerebellar stroke. And we know now what all the characteristics of peripheral nystagmus are, all the characteristics of central nystagmus are. We know what a direction of nystagmus means. Do we know? Yes. And what it is, the fast or the slow component? Yes, what is the slow component produced by? What is the fast component produced by? All that we know in great detail. And we also know that the direction of nystagmus is also telling us about where the disease is. If the direction of nystagmus in a peripheral pathology is towards the right, it is either a right hyperactive lesion or it is a left hypoactive lesion. All that we have done in great detail. Sometimes I really wonder whether I could have just told the facts and that would have squeezed the time so much. But yes, with the pattern of our exams becoming totally clinical, and when they are expecting you to actually learn and reproduce what you are actually going to face later on in your life, or now also when you are seeing the patients, I just hope it was worth it. Now, in the previous module, we saw what the vestibular physiology is. Also, we saw how to approach a patient of vertigo when we are suspecting positional vertigo or when we are suspecting vestibular neuritis, and how we differentiate it from a cerebral stroke. Now, another very important test that we have to test the vestibular function is the head impulse test. Yes. So what is the head impulse test? The name itself tells you that we are giving head impulse. Yes. So we are giving stimulus to the vestibular system. What the vestibular system picks up is the head movement. So what we are doing here is we are giving sudden movements of the head to the right and to the left, and we are seeing if the patient is able to fix the gaze on the object in the center or not. So what is that known as? That is what is known as the vestibulocular reflex. So what we are testing here is the vestibulocular reflex. So if this patient is turning the head to the right, what should be the normal vestibulocular reflex? If the vestibular system is normal, yes, it will sense the movement, it will send impulses to the eye, and the eyes will move at equally fast pace in the opposite direction, and the gaze will be fixed at the object in the center. Now, what will happen if the sensing mechanism is not properly functioning? So now when we give sudden movement of the head, if the labyrinth has become hypoactive, what will happen if we give sudden movement of the head? There will be an abnormality in the sensing mechanism, because of which the eyes will not be able to move equally fast in the opposite direction. So what will happen? Eyes with the head, they will move to whichever side the head is moving, and then they will try to come back to the object. So when they try to come back to the object, to quickly reach the object, they will make very fast movements. These fast movements are known as saccades. So let us quickly see how we do this test first. Yes, and then let us write down what the result will be. We are now going to see how we do the head impulse test. Now in this test, what we are testing is the vestibulo-ocular reflex. So we ask the patient to keep the eyes fixed on either the examiner's nose or on the camera while we give impulses to the head quick movement to the head, to the right or to the left. Now, if the vestibular system is normal, it will sense the head movement and it will quickly send the impulses through the vestibulocular pathway to fix the eyes on the object of interest. And we will see that in spite of giving quick head impulses to the right or left, the patient is able to maintain the gaze on the desired object. Now let us quickly see how we do the test and how its response is when it is normal. So we can see here, in spite of giving quick head impulses, the patient is fixing the eyes constantly on the examiner's nose or in the center, that is the camera. We just saw how a normal head impulse test looks like. Now, if there is a vestibular pathology, if the vestibular system is not functioning as in vestibular neuritis, then this will not be possible. And when we give sudden impulses to the head, the eyes will move along with the head. It will not be able to fix the gaze on the desired object, and then it will try to come back to the desired object by making corrective movements, which we call as saccades. So let us see how an abnormal head impulse test looks like. In this patient of vestibular neuritis, please note that the eyes move along with the head and then they make corrective movements to come back to the object of fixation. And those corrective movements are what are known as saccades. This is abnormal head impulse test, signifying that there is abnormality in the vestibular system. So we just saw how the head impulse test is done, and we can make out that this is a very simple OPD test by which we can find out the vestibular function. So if there is any patient who has acute vestibular failure, hypofunction of the labyrinth, in that case, when we do this test, the saccades will be present. We are testing the vestibular ocular reflex in this test, and yes, abnormality of the labyrinth will lead to an abnormal vestibular ocular reflex which will manifest as saccades. What are saccades? That the eyes will move along with the head and then to come back to the object of interest, it will make quick fast movements. These quick fast movements are known as saccades. Now the problem with the head impulse test is that it is not a very sensitive test, which means that it will pick up the damage only when the damage is a lot. Whereas if it is a little damage to the labyrinth, or if it is a damage which has got compensated by the other systems. Yes, so the vestibular defect, if a patient has a vestibular defect on one side, the patient does not for life remain vertiginous. If there is a damage of the labyrinth of one side, what happens is gradually over time, the center and the other systems which maintain balance, they compensate for that defect. So if we, in that case, if one side is hypofunctional and we want to find out that the side is hypofunctional or not, for example, if any patient has been given ototoxic drugs, he was vertiginous earlier, now he is okay, but we want to see whether the labyrinth is functional or not. Or for example, if any patient of meningitis, yes, we want to see that the labyrinth now is functional or not, or it has become dead. So in that case, the head impulse test will not pick up the abnormality of the labyrinth. In that case, what we can do is we can give another stimulus directly to the inner ear and see whether it is responding or not. And this stimulus that we are giving is not a normal physiological stimulus. When in head impulse test, we were giving the sudden jerks of the head, that was the normal physiological stimulus. That was what usually the vestibular system does. It senses the head movement. But now what we are doing is we are going to stimulate the labyrinth by giving it cold and hot water. That is not usually the function of the labyrinth. But what we are doing is we are seeing whether the cold water or the hot water is making the labyrinth respond accordingly or not. This test is what is known as the caloric test. So what is a caloric test? In caloric test, what we do is we do give different temperatures of water in the ear of the patient. So the first thing we need to know is how do we position the patient. The patient's position is like this. The head end is elevated by 30 degrees. Now why this position? Because in this position, the lateral semicircular canal becomes vertical and it is maximally responsive in vertical position. Maximally responsive. Yes, I have told this to you earlier also, and yes, this is a question that is asked in your exam. So it is 30 degrees up, 30 degrees, head end is raised. Now what we do, once we have placed the patient in this position, we give different temperatures of water. Different temperatures of water. What are the temperatures of water? We give cold water and we give warm water. So what is the temperature? Is plus minus 7 of body temperature. So 37 plus minus 7. So that makes cold as 30 and warm as 44. Okay, so don't think that if in the question is given that cold water test of caloric test is done with 15, 20, 25, 30. So, okay, 15 is looking colder. Let me do it with that. Or warm water test of caloric test is done with 40, 44, 50, 54. Okay, let me mark 54. No, this is the specific temperature that we test this, do this caloric test with. Cold is with 30 and warm is with 44. Now, if we are giving cold and warm water in the ear, can you tell me that if it is inducing convection currents in the inner ear by putting different temperatures of water in the ear, if we want to stimulate the inner ear, which semicircular canal are we stimulating? Which is the semicircular canal which is most accessible to us through the external auditory canal? In other words, which is the semicircular canal which bulges on the medial wall of middle ear? Yes, very good, the lateral semicircular canal. So this is another question that is asked here is, which semicircular canal is tested here? Yes, the lateral semicircular canal. And what will be the response when you do this test? Yes, the response is COWS, C-O-W-S. When you give cold water, the nystagmus will be towards the opposite side. When you give warm water, nystagmus will be towards the same side. Now, if I put cold water or warm water in your ears, will this be the response? COWS, yes or no? Or in my ear, if I put cold water and warm water, yes, will there be nystagmus? Will there be nystagmus to the opposite side with cold water and to the same side with warm water? Yes, what we are testing here, please understand this. What we are testing here is whether the labyrinth is normal or not, inner ear is normal or not. If the inner ear is normal, when I put cold water, that cold water, what does the cold water do? It makes the normal inner ear hypoactive. Yes, and if I put warm water, the warm water makes the normal ear hyperactive. Hence is the response. We know that whenever the labyrinth becomes hyperactive, it will lead to a nystagmus. We know that? Yes. Also, when the labyrinth becomes hypoactive, that also leads to abnormality of the vestibular-ocular pathway manifesting as nystagmus. In hyperactive lesion, or we always remember that nystagmus is towards the active side. So, hyperactive lesion, which is a hyperactive lesion? Hyperactive lesion is warm. Warm is hyperactive. By putting warm, how do you remember? Warm is, we know in warm we become hyperactive, in cold we become hypoactive. Yes. So when we put the warm water, what we are doing? We are making the labyrinth hyperactive. So the nystagmus is towards the more active side. So it is towards the same side. Whereas when we are putting cold water, we are making the labyrinth hypoactive. Nystagmus will be towards the more active side, that is towards the opposite side. Ultimately, what we have to remember is COWS. What is asked in your exams is COWS, that when you put cold water, nystagmus will be towards which side, and warm water, nystagmus will be towards which side. In other words, sometimes it is asked that when you are putting cold water, the fast phase is towards which side? Fast phase, when we say nystagmus is towards the opposite side or towards the same side, what we are telling is the direction of nystagmus is towards this particular side. Direction of nystagmus is what? It is the fast phase. We have seen all that very clearly in detail in the last module, right? So this is what we are seeing, and what I want to stress here is that if the labyrinth is normal in any person, when we make it hypoactive or hyperactive by different temperatures of water, it will respond accordingly. Whereas if somebody's labyrinth is destroyed, it is not functional. It is not functional. So whether you put cold water or whether you put warm water, will it respond? It will not respond. It will not respond. It will not respond means with cold water, it will not become hypoactive. With warm water, it will not become hyperactive. So when it will not become either hyperactive or hypoactive, then it will not lead to any changes in the eye. It will not lead to any changes in the vestibular-ocular pathway. There will be no nystagmus. So when we are doing this test in anybody, and if this is the response that we are getting, we say that in this person, the labyrinth is normal. Whereas if we are doing this test and we are not getting any response, or what the response that we are getting is very minimal as compared to what we consider as normal, then that tells us that the labyrinth is not functioning properly. It is hypofunctional. So in normal, this is the response. This is the response of normal labyrinth. So the significance of the caloric test is that this can be used to test each of the years separately. Test each labyrinth separately. Labyrinth separately. And if the labyrinth is dead or it is hypofunctional, what happens? In dead labyrinth, there will be no response. With any temperature of water, hypofunctional labyrinth, there will be decreased response when we put this different temperatures of water in the year. Now, if you have put this water into the ear and the labyrinth is not responding, then to confirm that the inner ear is dead, what we do is another test which is known as the Kobrach test. It is known as Kobrach. What is this Kobrach test? In this Kobrach test, we put ice cold water because when we put the 30 degrees water, it was not responding. So we want to see that is the labyrinth totally gone? Even with ice cold water, maybe it will respond little if it is little functional also. So we put ice cold water. Ice cold water. Okay, so that is why the caloric test where we are putting cold and warm water, that is what is known as bithermal caloric. Why bithermal? Because we are using two temperatures of water there. Bithermal test, or it is also known as Fitzgerald Hall-Pike test. Now, please don't confuse Fitzgerald Hall-Pike with the Hall-Pike test of BPPV. Okay, this Fitzgerald Hall-Pike is another name for caloric test. So, in Kobrach test, what we do is we just put ice cold water. We start with 5 ml. If there is no response, we go up till 40 ml. And if there is still no response, then we declare that the labyrinth is dead. So now we know of two very quick tests which we can do in the OPD to find out whether vestibular system is functioning or not. One is the head impulse test and the other is the caloric test. Okay, quickly tell me, if on head impulse test there are saccades present, vestibulocular reflex is not normal, saccades are present, then where is the abnormality? Yes, it indicates a peripheral vestibular abnormality. Okay, if I am doing caloric test, tell me caloric test with cold water, nystagmus will be towards which side? The fast component of nystagmus will be towards which side? Opposite side. The slow component will be towards which side? Towards the same side. Yes, when I say fast component towards the opposite side, it indicates slow component will be towards the same side. Okay, when I put warm water, then nystagmus is towards which side? Towards the same side. That is the fast component of nystagmus. Now, whenever we are doing caloric test, we test with warm and cold water, and whenever we are putting warm and cold water, in between we give time for the labyrinth to come back to normal, which means that we have to give a gap between cold and warm water of at least 5 to 8 minutes. So, at least 5 to 8 minutes gap has to be given. And the characteristic of this nystagmus will be the same as the peripheral nystagmus. So all these characteristics now you are going to tell me. Yes, tell me quickly. Latency will be present, yes or no? Latency, yes, present. Duration, will it be limited? Yes, it will be limited duration. Yes. Will it be horizontal or vertical? When you are doing caloric test, you are stimulating with semicircular canal, horizontal semicircular canal. So the nystagmus will be horizontal with the torsion. Yes. Optic fixation, will it disappear? Yes or no? Yes, it will disappear. It will disappear. And what will be the direction of nystagmus? We already know with cold it will be towards the opposite side, and with warm it will be towards the same side. So that is what we need to know in the caloric test, a very, very commonly asked test of your exam. In patients in whom there is a tympanic membrane perforation, we cannot put water in their ears. In those patients, how will we do the caloric test? Yes, for them, what we do is we use apparatus which is known as a Dundas Grant tube. What is this? It is a coiled copper tube, as you can see in this picture, and ethyl chloride is put inside this tube to cool the air. and now the air is passed through this tube into the ear. So now cool air will go into the ear, and that will make the labyrinth hypoactive. So this, what you're testing, is only cold, with cold air. So it is known as cold air caloric testing with Dundas Grant tube. And the nystagmus that you will see will be towards the opposite side. If the labyrinth is normal, it is responding normally, then the nystagmus will be towards the opposite side. Another significance of the caloric test is that it can be used to test the brainstem integrity in patients of coma, to test whether this patient is brain dead or not. Now we know what we are doing by the caloric test is that we are stimulating the labyrinth here, yes, and what we are seeing is that in response to stimulation of the labyrinth by cold or warm water, whether this vestibular ocular pathway is normal or not, resulting in appropriate eye movements. Now this vestibular ocular pathway we know passes through the vestibular nuclei. This vestibular nuclei is present in the brainstem. So if this response is normal, then we take it for granted that the whole pathway is normal, which means that the brainstem is functioning in this patient of coma. Why not do the other test of the brainstem of other nuclei? Yes, we know that in the brainstem we are present multiple cranial nerve nuclei. Why are we specifically doing the caloric test? Yes, we have the 3rd, 4th, 5th, 6th, 9th, 10th, 11th, all these nuclei. In a coma patient, can you test the 3rd, 4th, 6th? Can you ask the patient that move your eyes right, left, up, down? Tell me the sensation, whether you are feeling the sensation or not. Yes, you can open his mouth and look for the response or not. No. So here in this when we are testing the caloric test, we do not require any response for the patient. We do not require the patient to respond for us to know the result. We will just give cold water and we have to just see the response in the eye. Patient's cooperation is not required. That is why we can use this test to find out the brainstem integrity in coma patient. Again, this was a question of your exams. Now suppose I press and release your tragus repeatedly. Yes, your pressure of external aortic canal will increase. Yes or no? Yes. This pressure, increased pressure of the external aortic canal will get transmitted through the tympanic membrane to the middle ear. Yes or no? Yes. And then it will go to the inner ear. Yes or no? If it goes to the inner ear, if you say yes, so it means that your inner ear will get stimulated, you will have very severe vertigo and you will fall down. Yes or no? No, does not happen. No, it does not happen. So why? Okay, eustachian tube. Eustachian tube is equalizing the pressure. Okay, which means that if in any patient the eustachian tube is blocked, and then you do this, you change the pressure, you increase the pressure of external aortic canal. Now the eustachian tube is blocked. So now the pressure of the middle ear will go into the inner ear, stimulate the inner ear, and the patient will have vertigo and he will fall down. Yes or no? So this is a very easy method of giving vertigo to your enemy. Take him out, give him lots of ice cream. So now the eustachian tube will get blocked. Now go near him and do this. Now his eustachian tube is blocked. So pressure will go to the inner ear. He will have vertigo and he will fall down. Yes or no? Don't waste your money on ice cream. This will not happen. Why? Yes, because such small changes in pressure will go through the tympanic membrane to the middle ear, but not to the inner ear, unless and until there is a communication between the middle ear and the inner ear, which means that there is a communication on which wall? On the medial wall. And what do we call an open communication? What do we call open communication? Yes, a fistula. So unless and until there is a fistula on the medial wall, this will not happen. Which means that if there is a fistula on the medial wall of the middle ear, what will happen is small changes of pressure externally will go into the inner ear and stimulate it, and these patients will come to us in the OPD with a complaint of vertigo on pressure changes. So what pressure changes? Do they tell us that whenever I do this I have vertigo? No, they will tell that whenever I cough, whenever I sneeze, whenever I lift heavy weights, all these things increase the pressure. So then I have vertigo. So don't just think that this patient is malingering. Yes, on coughing, on sneezing, or on lifting heavy weights. Who has vertigo? So when any patient is complaining like this, always rule out a fistula. Fistula where? Fistula on the medial wall. How can you rule out a fistula on the medial wall? Either by tragal pressure or you can use a Seagal speculum. So first is, when you will do this test? Yes, you will do this test Whenever the patient has vertigo and external pressure changes, small pressure changes which are usually not supposed to lead to vertigo. For example, coughing, sneezing, lifting heavy weights, and we can do it either by tragal pressure or by this instrument which is known as Siegel's speculum. So what will be the result? So here we have the medial wall of the middle ear. So when will the fistula test be positive? So fistula test, for it to be positive, we know that there has to be a fistula on the medial wall. So quickly tell me what the structures are on the medial wall. I will draw and you tell me what this is. Yes, this is very good. This is the promontory. Very good. Here we have very good oval window. This is round window. And what is this? This is the bulge of some semicircular canal. Yes, the lateral semicircular canal. So whenever there is a fistula over the lateral semicircular canal, fistula over the oval window, over the promontory, over the round window, in all these cases, the fistula test will be positive. Now, there was a surgery which used to be done for footplate of stapes fixation. Where is the footplate present? On the oval window, right? So when the footplate was fixed, that was known as otosclerosis. That is known as otosclerosis. So what surgeons used to think that, okay, footplate has got fixed. How will the sound go inside? They saw another bulge above it. That was, what is this bulge? This is the bulge of lateral semicircular canal. What they did is they made a fenestra over it. Fenestra means opening. So they made an opening over it so that, okay, sound, this opening is fixed. So let the sound go through this opening, that new opening that we have made. But what happened following surgery? So they have made a fistula. So small pressure changes also, they went into the inner ear, stimulating and leading to vertigo. So that was not at all acceptable. It is no more done now. So this was known as fenestration operation. So fistula test is positive in any fistula on oval window, round window, promontory, lateral semicircular canal, in fenestration operation. Now, there are certain conditions where even if there is no fistula on the medial wall, the fistula test will be positive. How come? So here we have the membranous labyrinth, and here we know that around the utricle and saccule, this part of the bony labyrinth, around the utricle and saccule is what is known as vestibule. And the vestibule is connected to the middle ear by, quickly tell me, V for vestibule, V for oval. Yes, V of oval tells you V of vestibule. Oval window. Okay. So what is present on the oval window we know is footplate of stapes. So footplate of stapes is present here. So even if there is no fistula on the medial wall, can the footplate of stapes stimulate the utricle and saccule leading to vertigo? It can in two situations. Which two situations? Yes, either the utricle and saccule is dilated. Either the utricle and saccule is dilated and it is very close to the footplate, because of which small pressure changes also, when it leads to movement, it is stimulating the inner ear, stimulating the utricle and saccule leading to vertigo, or the utricle and saccule is not dilated, but the footplate is hypermobile. Footplate is hypermobile. So in these cases, there is no fistula on the medial wall. Still, the fistula test is positive. So when the fistula test is positive without a fistula on the medial wall, that is what is known as the Henne-Bird sign. Henne-Bird sign. What is Henne-Bird sign? Henne-Bird sign is false positive fistula. False positive fistula. False positive fistula means that the fistula test is positive. Positive. But no fistula on medial wall. On medial wall. Yes, so this will be seen in which conditions? Yes, it will be seen when the utricle and saccule is dilated. Any condition you know of where the utricle and saccule will be dilated? Yes, in Meniere's. Or in hypermobility of the footplate of stapes. We know of any condition where the footplate of stapes is hypermobile in congenital syphilis. Another very important condition where the Henne-Bird sign is positive. Henne-Bird sign is positive means that the pressure changes will lead to, external pressure changes will lead to vertigo without a fistula on the medial wall, is superior semicircular canal. Superior semicircular canal dehiscence. Yes. Where is the bulge of superior semicircular canal? We know it is in the base of skull on the anterior slant of pitris bone. If it is gaping, if there is a dehiscence over that. So now when the foot plate moves, what happens is it produces abnormal movement of endolymph in the superior semicircular canal because of this abnormal opening here. So that stimulates the superior semicircular canal leading to vertigo, whereas there is no fistula on the medial wall in this condition. So this is another condition where the Henneberg sign is positive. In superior semicircular canal dehiscence. Now, sometimes what happens is that there is a fistula on the medial wall and the patient has come to you with these complaints of vertigo on sudden pressure changes, on coughing, on sneezing, on lifting heavy weights, and you tell the patient that yes, you do the fistula test, it is positive, that there is a fistula on the medial wall and obviously it needs to be repaired. Yes. So the patient is not very convinced. Why? Because he has vertigo only sometimes, not all the time, only on pressure changes. So he just let it be. He is not getting the surgery done. After some time, the patient comes back to you again and he says that, see, now my vertigo is gone by itself only. I did not get any surgery done. So you ask the patient, then why are you here if the vertigo is also gone now? Yes. So now I have complete hearing loss. I cannot hear anything from the ear. So what do you think happened that the fistula test, which was initially positive, now has become negative? Yes, the fistula will not repair by its own. What has happened? Yes, either the inner ear has become dead because the disease now has progressed. The inner ear has become dead and in spite of the fistula, it is not responding. Or because of progression of the disease, in the middle ear, which led to a fistula or for example, a cholesteatoma that has now come and covered the fistula. So that has come and covered the fistula, because of which, in spite of the fistula, the pressure changes are not getting transmitted to the inner ear. So then the fistula test will be negative, but it will be falsely negative, because there is a fistula, but the test is negative. So that is what is known as fistula test false negative. That will be seen in which cases? Either in dead labyrinth or in cholesteatoma covering the fistula. Okay, so quickly keep your pens down. Yes, and tell me, patient has come to you with a complaint of posture change, vertigo and posture change. What are you going to rule out? Yes, BPPV. Patient has come to you with continuous vertigo. Then, yes, vestibular neuritis, that you're going to differentiate from cerebral stroke. Okay. Patient has come to you with vertigo on coughing or sneezing or on pressure changes, external pressure changes. What are you going to rule out? Yes, very good. A fistula. In which cases will the fistula test be positive? Quickly tell me. For positive, only a positive fistula test. Fistula over oval window, round window, lateral semicircular canal. Yes, that can occur because of trauma or it can occur because of disease. False negative fistula. In spite of fistula being there, fistula test is negative. Yes, in which cases? Dead labyrinth or in cholesteatoma covering the fistula. Yes, which surgery will lead to a positive fistula test? Which surgery? Yes, fenestration operation. When will the fistula be false positive? What is false positive fistula known as? False positive means there is no fistula on the medial wall. In spite of that, the fistula test is positive. False positive fistula is also known as Henneberg sign. Henneberg sign is seen in which conditions? Yes, in Meniere's, in superior semicircular canal dehiscence, in congenital syphilis. Now, all these patients where there is pressure changes leading to vertigo, these patients will also complain on loud sounds leading to vertigo. Why? Because these loud sounds, normally, they will be going into the inner ear, but because of stapedial reflex, ultimately later on what will happen? The entry of the loud sounds will be hampered. But if there is abnormal communication like a fistula on the medial wall, they will directly go into the inner ear, excessively stimulated, leading to vertigo. So whenever there is vertigo on loud sounds, again, we have to rule out all these conditions, fistula on the medial wall or a abdominal opening like a superior semicircular canal dehiscence, where the increased loud sound is going and it is stimulating. It is causing abnormal movement of the endolymph in the area of the superior semicircular canal because of abnormal communication there. So whenever the patient comes with vertigo on loud sounds, yes, we have to rule out these conditions. But how will we rule out? So what is vertigo on loud sounds known as? Vertigo on loud sounds is known as Tullio's phenomena. So vertigo on loud sounds is known as Tullio's phenomena. And this will be present whenever there is abnormal communication between the middle ear and inner ear, or there is an abnormal opening at the level of superior semicircular canal, or when the footplate is very close to the utricle and saccule, where loud sound is excessively stimulating the utricle and saccule, leading to vertigo. So it will be positive in which conditions? Quickly tell me. Yes, whenever there is a fistula on the medial wall. Yes, whenever there is superior semicircular canal dehiscence. Whenever there is abnormal dilatation of the utricle and saccule, bringing the utricle and saccule very close to the footplate, that is Meniere's. Or also in congenital syphilis. But how are we going to test this, whether loud sounds are actually leading to vertigo in this patient or not? Okay, just think and tell me, do loud sounds in us also stimulate our inner ear, the vestibular system? Obviously, it stimulates the hearing, the cochlear part. The loud sounds will go to the organ of Corti. But do loud sounds in us also stimulate our vestibular system? What do you think? Yes or no? Yes, it does. It does stimulate. And this trick you have been using since you were a child. Yes? What you used to do? You used to hide. When somebody was coming, you knew, you used to hide behind. And suddenly when you see that person coming close, you will do tappa. Like that, yes? So what was the response in that person? Was it, oh my God, such a loud sound. Why did you shout? Was it like that? No. What was the response? Like this. So what happened in response to the loud sound? In response to the loud sound, the vestibular system sensed the loud sound. Why? How? So with the movement of the footplate of stapes in loud sounds, when it was initially a little more till the stapedial reflex get activated. What is the stapedial reflex? Afferent is 8th nerve, right? The auditory pathway senses that there is a very loud sound. Only then the efferent, the 7th nerve, gets activated. So initially when the footplate will move more, now what will happen is that in us also, the utricle and saccule, because of excessive movement of the footplate here, the utricle and saccule in us also gets stimulated with loud sounds. And what is the response? If the sound is very loud, suppose there is a bomb which explodes somewhere, what do we do? Like this. So how did that loud sound give us this response? Yes. So what happens is that the loud sound, it stimulates the saccule. From the saccule, through the inferior vestibular nerve, it goes to the sternocleidomastoid of the same side. Yes. So if the loud sound is coming here, from the saccule through the inferior vestibular nerve, what is this? The vestibulospinal pathway, right? This is the vestibulospinal pathway. Spinal pathway. So it does not respond only to movements, it also responds to sound. So what happens in response to that? There is a sudden relaxation of the sternocleidomastoid muscle of the same side, leading to relaxation. At the same time, where there is a loud sound, what do we do? Yes, not only this, eyes also blink. Yes, so that reflex goes from the utricle. So this impulse is going through the utricle, through the vestibulo-ocular pathway, to the eye muscles of the opposite side. And this response is what is known as vestibular evoked myogenic potential, which can be either a cervical vestibular evoked myogenic potential, or we call it as CVEM. CVEM. What is CVEM? when the stimulus is going through the inferior vestibular nerve to the sternocleidomastoid, that is known as cervical vamp, or if it is going to the eyes through the utricle, this is what is known as ovamp or ocular vamp. So this is what is known as vestibular evoked myogenic potential, and this is a test for the vestibulospinal pathway. So in us also, if we do this test, what test? Yes, we give a sound, a loud sound, and we look for the response in the sternocleidomastoid muscle. In us also it will be positive, but in people in whom loud sounds is leading to vertigo, it means that the inner ear is hyperexcitable to loud sounds. In whom the Tullius phenomena, what is Tullius phenomena? Vertigo on loud sound. So in whom the Tullius phenomena is present, this loud sound will lead to excessive response when we do this test. The potentials will be high amplitude. Also, it might be present even at a low loudness. The low loudness is also going to go into the inner ear excessively and stimulated. So that is what the VEMP test tells us, and that is when we do a VEMP test. So whenever a patient comes to us with vertigo and pressure changes, we will go for fistula test. Whereas if the patient comes to us with vertigo on loud sounds, again what we have to rule out are the same conditions, but we will go for what test now? We will go for VEMP test. And again, this has been asked in your exam. The C-vamp is mediated through which nerve? Yes, it is the inferior vestibular nerve. So now what we know is that when the labyrinth becomes hyperexcitable and there is vertigo and posture change, then we do which test? Yes, Dix-Hallpike. Quickly tell me. Yes, you will have to tell. Or supine roll. Yes, when there is vertigo and loud sounds, Tullius phenomena, then we go for VEMP test. If there is vertigo and pressure changes or Hennebert sign, then we go for fistula test. Now here, in this patient who is standing in front of us, can we find out whether her vestibular system is functioning normally or not by testing the vestibulospinal pathway? Now we know that if there is any abnormality of the vestibular system, it will reflect as an abnormality of the vestibular ocular pathway as well as the vestibulospinal pathway. So if I want to test a vestibulospinal pathway, can I test the vestibular system by that in her? How can I? In this patient, the input for balance is not coming only from the vestibular system, it is coming from the vision also. It is coming from the proprioception also. Okay, vision we can remove. How? Okay, so I've made her eyes close. So yes, the vision is gone. Proprioception, how should we remove that? Yes, for removing the proprioception, what we do is we ask the patient to do very fast stepping movements, around 90 steps per minute. Yes, as just seen in this video. Yes. So this test is what is known as Unterberger or Fukuda stepping test, and it is a test for the vestibulospinal pathway, or it is also known as vestibulocholic reflex. Now, if there is any abnormality of the vestibulospinal pathway, what will happen is, since we have removed the ocular input and the proprioception input, if the vestibular system of one side is hypoactive, the normal vestibular system will push the body to the other side. The other side is not able to push the body equal and opposite, so the body will move towards the affected side. That is what the function of the labyrinth is. I have told you in so much detail in the last video that the right labyrinth pushes the body or to eye. There we did the eye. Here we are doing the body. Yes, the body to the left and the left pushes the body to the right to maintain the posture. So here what is happening, if one of the labyrinth is hypoactive, suppose the left is hypoactive, the right is now active, so it will push the body more towards the right. So what will happen is, the patient while doing this test will rotate more towards one side. Yes. So the body will deviate to the weaker side. The normal side will push it towards the weaker side. So that is what we call as a positive test, a positive Fukuda's test. Yes, so keep your pens down. Yes, can you now rule out a BPPV? Yes or no? Yes, okay. Can you diagnose a vestibular neuritis when the patient has come to you with vertigo? When the patient has come to you with vertigo and pressure changes or on loud sounds, can you rule out if there's a fistula or Meniere's or superior semicircular canal dehiscence? Yes or no? Yes. Can you test the vestibular spinal pathway in the OPD itself? Yes. What test is that? Fukuda stepping test or Unterberger test. Yes. Can you test the labyrinth separately by non-physiological stimuli? What is that? The cold water or warm water. What test is that? That is a caloric test. So now we know that whenever the patient comes to us with different presentations of vertigo, what are the various vestibular function tests that we are going to do and what abnormality we are going to find there to confirm that this is a vestibular abnormality. And the main aim is always to come to diagnosis. Once we have come to a diagnosis, treating part is not difficult. But to come to a diagnosis is what we aimed at doing in this module. And I hope we have succeeded in doing that. So you can just open your questions and finish doing them.